Good afternoon and welcome to OC Talk, the show dedicated to helping home health and hospice providers keep up to date on the documentation, diagnosis coding, OASIS, and HOPE assessment data collection issues that matter most in home health and hospice. OC Talk aims to bring you closer to reliable experts in home health and hospice and to share the latest news and information from the industry and from the Association of Home Care Coding and Compliance. I'm Jan Milliman, Director for OC, and I'm happy to be hosting today's program. This afternoon, we're talking about social determinants of health. And now I'd like to introduce our industry guests for this episode. We have two members of the OC Advisory Board on the call today. We have Sherri Parson, CEO with Infusion Health on the call, and we have Kelly Kavanaugh, Home Health and Hospice Consultant and owner of the OTB Group with us today. Thanks so much for joining us today.
Glad to be here.
It's great to have you. And let's get the conversation started. Listeners, if you have any questions for our panelists today, please go ahead and ask them in the chat pane, and we'll try to get to as many as we can. And Sherri and Kelly, I'll turn things over to you, and just let me know when you need me to advance the slide.
Okay, thank you, Jan. All right, so as Jan mentioned, we're going to talk about the social determinants of health today, and we're going to talk about some different things surrounding social determinants of health, such as how they relate to coding and OASIS, and then some things that you may want to look at doing for your patients based on the social determinants of health that may be going on in the home. So Jan, next slide. We're going to start talking about the coding of social determinants of health and what you need to know to assign those social determinant of health codes. So because the social determinants of health can touch a lot of different areas in your patient's environment, from educational abilities to socioeconomics information, their healthcare access and quality, and things going on in their environment. So it touches a lot of information in the home. So some things that you need to know from a coding standpoint, next slide. They can be coded, social determinants of health can be coded from clinician documentation in the patient record. So this is a little bit different than what we're used to in the coding world, because we don't have to have it from a provider. So it doesn't have to be a physician or a nurse practitioner or a physician assistant that documents these things. We can take it from clinician documentation. So those things can be coded based on what your clinicians are saying. So we do have some code expansions that have happened in prior coding time frames that have aligned with this whole now vision of taking really a closer look at the social determinants of health in our patient population. So we need to look at how that affects our patients and our interventions on our care plans as well. And we are able to assign as many of those social determinant of health codes as needed to paint the clinical picture. Now, obviously, you don't want to just go crazy with it, because you want to take a look at what is actually affecting your plan of care. So just the fact that somebody has this situation and there's a code for it doesn't mean it actually belongs on your plan of care, right? So you want to take a look at what's actually going on in that clinical picture of your patient and what's going to be significant to your plan of care. So an example of that would be a patient who lives alone. There may be lots of patients who live alone. It may not be a problem in the world for a lot of patients, so you wouldn't want to just arbitrarily assign the code for Z60.2 problems related to living alone if there's not a problem with them living alone. Okay, so you got to look at the whole picture. So that code's not for just the fact that they live alone, it's that they have a problem with living alone. Now that problem could be an unmet need, or it could be just that there's an increased risk situation for this particular patient because they live alone. So patient self-reported information, however, we need to be sure that that's getting documented and incorporated into the medical record, and that will ultimately get signed off by a clinician or a provider. So patient said this and that, if that gets documented by the clinician, then that's good information, and we need to have that in our medical record as backup for using those codes. Okay, next slide. All right, so let's talk about the scenario that we had from the prior OC Talk in February. We threw out this scenario. The patient was admitted to home health with a decline of their COPD, recent hospitalization. Patient lives alone, and they can complete all their ADLs and IDLs slowly without assistance. Per the medical record, patient's respiratory decline is thought to be related to a lack of money for proper heat and increased dampness and mold at home. The patient also states they do not take their meds as prescribed due to the lack of money for both food and meds. Admitting nurse writes a progress note, contacts the provider, gets a social work referral order. So what would be the best coding assignment for this scenario? So on the next slide, we'll look at the answers. So the answers for the coding scenario, we have the COPD, of course, coded there with the J44.9, and then we added some social determinant of health codes. So we've got the other specified lack of adequate food. We have the inadequate housing utilities because we don't have the heat, so it increases the mold and etc. for their respiratory status. And then we have the patient's intentional underdosing of their medications due to that financial hardship. So a couple of questions that you may have with this: why didn't we code J44.1? Well, we didn't code 44.1 because the record just states a decline. They did not say there was an exacerbation to their COPD. So we can't code exacerbation unless the provider indicates there was an exacerbation. Why didn't we code living alone in this situation? Well, there was nothing in our scenario to indicate the patient was having any kind of problems with living alone. It just pointed out that she lives alone. Now we've got some other things that we did code. We coded several others. Is this too many codes? Well, no, because we're painting the picture. We want that clinical picture of this patient to adequately support what's going on in this patient's home, to help support the social work eval that we obtained from the physician. So this adequately paints the picture of what's going on with our patient. Next slide.
Right.
So,
well, thanks,
go ahead.
Kelly.
I was just going to say,
so-
and now for Sherri.
Yeah. So, you know, we always like to go back to the guidelines. You know, we give you these recommendations and they're based on something. So there is that reference for the guideline here that we're not going to just assign Z60.2 for merely living alone, but there has to be that risk or unmet need. This is where you would find it. So I think it's always helpful to have an example of what that looks like, so we know when it is that we would maybe assign this code. So here's an example. Patients noted to have repeated falls and takes anticoagulants and antiplatelet drugs. This could be a safety concern for someone who lives alone. It would then be appropriate to go ahead and assign that Z60.2, problems related to living alone. And as we told you before, you're going to make sure that that's incorporated in your medical document. Next slide, please. All right, so we kind of jumped into everything. So we just want to make sure we talked about the domains that affect social determinants of health, but we want to set the table, if you will, make sure we all understand the definition, the official definition here. Social determinants of health are the conditions in the environments where people are born, live, learn, work, play, worship, and age that affect a wide range of health functioning and quality of life outcomes and risks. And if you look there, you'll see Healthy People 2030. That's a initiative that's part of the Department of Health and Human Services. So we're going to talk a little bit about that in a minute. And then you can see all 5 domains here. I think our initial picture we had cut off that social and community context on the bottom there, but you can see all 5 domains that feed into the social determinants of health. Next slide, please. So I think it's easy to think, well, we're getting all these new codes, we're getting, OASIS questions related to social determinants of health, and it's easy to think, oh, this is something that's just popped up. But what I just wanted you to understand with this slide is how long this stuff has been brewing before it actually was implemented in our coding set and our OASIS. World Health Organization back in 2005 sounded the alarm all around the world that we had disparities worldwide in the care of individuals based on social determinants of health. Now, the U.S. Department of Human and Health Services, they came up with that Healthy People initiative that I was just showing you at the bottom of that slide. And the concept with this is in 10-year increments, we will improve the health care for the entire population. So 2000 to 2010 was one of the initiatives, 2010 to 20. Right now we're in 2030 because they have objectives to improve health care related to social determinants of health across the entire population. Then we have the Office of Assistant Secretary in Planning. They did a couple very key studies, one in 2016, one in 2020. They commissioned the National Academy of Science and Medicine and Engineering to do these. And believe it or not, social determinants of health were looked at in the context of value-based purchasing. Very interesting, because now what kind of model are we in? We're in the value-based purchasing model as well. And then in 2018, the 115th Congress enacted the Health Equity and Accountability Act that introduced programs, requirements related to health of minority populations. Next slide, please. So just quickly on those two studies, what they basically started doing was looking at social determinants of health. What did they find out? There's no standardization. Not always was it even being looked at. And those people that had social risk factors had poorer outcomes than those that didn't. And a matter of fact, providers that had high populations of those with social determinant of health risk, we couldn't even risk adjust away their poor outcomes as providers, because nothing could really accommodate the outcomes that they were seeing with this population. One of the key indicators of poor outcomes was dual enrollment. If you had a patient that was Medicare or Medicaid, you could almost be assured that they were going to have poor outcomes based on that status. 2020, they repeated the study and still determined that there was no standardization. Why we've got OASIS questions now, so that we can standardize what it is we're looking at. Because if we don't standardize what we're looking at, we don't know how to improve it. We don't know what works when we improve it. And we are just comparing apples and oranges, and we're not getting anywhere with actually solving that issue. And again, they still saw the same thing, that dual enrollment is the single most powerful indicator of poor outcomes. Next slide, please. Okay, I think this is you, Kelly.
Okay, so one thing I just want to point out here when we're looking at social determinants of health in our patient population is to kind of watch out for personal bias. So, you know, we're in a lot of homes, we go in and out of a lot of homes, we're in a home care, industry. And so we have to kind of see, is something going on in the environment that is making this patient unsafe, or are there things that are going on that need to be fixed or changed, or is the patient kind of functioning okay in this environment, and is it truly a problem, or is it not a problem? So we have to look at it from the patient's perspective and not necessarily our perspective or our personal belief in how somebody's situation should be, and if they're choosing to be in a situation versus somebody who may be in a situation and they don't want to be in that situation. So looking at the social situation is sometimes a little bit tricky, and emotions and things can get involved. So we have to just be sure that we're doing it from a clinical perspective and looking at the safety and vitality of the patient from that perspective.
Hey, Kelly, could I add a personal example here? Because
Absolutely.
I really found myself, and this is really shameful, but when I was a home care nurse, I kept thinking, boy, these people wouldn't end up in ER if they had themselves a family physician. But what I didn't understand was I didn't understand the dynamics of social determinants of health. If you live in some of these neighborhoods, there may be one physician only in the inner city that is servicing too many patients. When they're acutely ill, they can't get in there. Or they have transportation issues. They can't get to the physician because they've got to take 2 buses to get there. They can't go at a specific time. And I was, just so ignorant to the fact that there are obstacles, social determinant wise, that prevent people from having family physicians to deal with their issues because of social determinants of health. So just, a bad look at myself, but just where this personal bias can sometimes come in, it's really very subtle sometimes.
Absolutely. Thank you for that personal scenario there. Appreciate that information, but that does drive home the point for sure. So next slide. So on our OASIS, we have additional items that, some people may, when these first started coming about, you're like, why am I having to answer this? What is this all about? Well, this is kind of what this is all about. This is kind of the beginning of the social determinant of health items, which I'm assuming is going to expand over time, but this is kind of where they chose to start. So we do have quite a few items on our OASIS now: the race and ethnicity, the language, interpreter services needed, health literacy, transportation, and social isolation are the kind of the beginnings, the tip of the iceberg of the social determinant of health development into our OASIS. So we want to be sure that we're answering these questions. Now, some of them seem pretty easy, that, kind of just, check it and forget about it kind of scoring, but we want to be sure that we're answering these to the best of our ability and follow the guidance for each one of these items. So next slide. So we want to be sure that we're evaluating that on a global perspective for your patients. So you have to look at the guidance is different for each one of these items. So you have to kind of look at what items are patient self-report only items, and what items can you use a proxy to answer, or a caregiver that can answer for the patient, and then what to do if your patient refuses to answer one of these social determinant of health items. So the social determinant of health items are all, like I said, they're all different, and they all are scored a little bit differently. And we're going to talk about some of the differences as we advance through the next slides. So on the ethnicity question, this, again, pretty straightforward question. However, if the patient, has the ability to answer, they're able to understand the question, but they decline to respond or refuse to answer this question, then you have to score it as patient declined to respond, which is the choice Y. If they are unable to respond, let's say a dementia patient, for example, if they're unable to respond, then you would mark that they are unable to respond, choice X. But then in addition to that, you would also score from a caregiver or a patient advocate, a chart. You can, anywhere you can find the information on their ethnicity, then you would be able to score that the correct answer for their ethnicity, in addition to patient unable to respond. So you would have 2 scores in that situation. But again, if the patient refuses or declines to respond, you can only mark that they declined, and that would be the choice Y. Excuse me. Okay, so next slide. Okay, so the next question is the race question. So we want to address this similarly. So we want to be sure that we're answering these correctly and to the best of our ability. And again, it's very similar here, where if the patient declines to respond, then you would use the choice Y and only the choice Y. And if they're unable, in the case of dementia, the choice X, and then attempt to obtain the correct answer from any available source to get the correct answer to include on your documentation. Language is similar. You would enter the patient's preferred language that they primarily speak. Ask them if the interpreter is needed, and if the interpreter is needed, then you would answer the item B if they need the interpreter to communicate with doctors and healthcare staff. If the patient is unable to answer, you can check with family members and significant others and answer accordingly. And if none is available, then you would check unable to determine as a last resort. And American Sign Language is a preferred language if they are hearing impaired, so that is considered a language for this item. Oh, sorry, Sherri, I think this was supposed to be your slide.
It's all right. We're getting the information out there. I'll take the next one. That's fine. No worries. No worries. All right. So when we're coding literacy and social determinants of health, how do we know when we use these codes? How do we know we have a problem? Well, it gets back to that clinician interview. And some of these can be very difficult to discern. individuals that have low literacy may have over time found coping mechanisms that make it hard for somebody to actually pick up on it. So we do need to probably ask and interview about these sensitive topics. And so getting used to talking about difficult situations, whether that's role playing with a coworker, so that we can, get used to actually having these tough conversations, is probably going to be something that we're going to all have to do in our organizations. But some codes, just to kind of give you guys an idea, Z55.0, low level literacy. Now again, you may not pick up on that with what you're doing during your interview. So you may have to ask a few questions to get to that. Z55.8, specified literacy, not elsewhere classified. So there's some other thing that's going on related to their literacy that's causing an issue. Z55.6, problem related to health literacy. Now, health literacy is a little bit different than language literacy, and we're going to talk a little bit about that on the next slide. So health literacy is more the ability to understand your care, treatment, and being able to assimilate that information into what it is that you're doing for your care as an individual. Z55.9, unspecified problem with literacy. Next slide, please. So again, back to that healthy people, you can see that they are really active in a lot of things there. So personal health literacy is the degree to which individuals have the ability to find, understand, and use information and services to inform health-related decisions and actions for themselves and others. And so here is a great statistic that just made me almost fall when I read this. National Academy of Science, Engineering, Medicine said 9 out of 10 adults lack health literacy needed to manage their own care. So, we think of individuals and we think we're dumbing down, if you will, the information that we're teaching them. But the thing is, we talk in terminology that they don't understand, extremity. Rather than saying arm, leg, sometimes a word like extremity is not something that they're used to. But one of the things with health literacy is sticking to things like this. What we're looking at right here, a graphic like this makes things easier to understand, less words, more pictures. And so again, getting some of those types of tools for your organization will go a long way in communicating, but we have to meet our patient where they're at. Next slide, please. All right, Kelly, we're back to you.
Okay, so the impact of health literacy, like Sherri said, it's a lot. We've got a lot of information goes into that health literacy. So it touches a lot of aspects of our care, and all of these things can affect your patient outcomes. If your patient has less knowledge about their overall health, their healthy habits, it could lead to more urgent MD visits, urgent care trips, ER visits. The health literacy issues can affect your outcomes in many ways, with confusion with their treatment plans. They don't know how to take their medications. They don't know how to follow their home exercise program. So if all of this is written in those terms like we talked about, then they could be missing out on a lot of information. And a lot of times they won't necessarily tell you outright that, hey, I don't understand. They'll just kind of nod their head and then go along with you and agree to, oh, yes, I do that or whatever. And they really don't understand what you're telling them. So small doses, small pieces, simple terms, simple words, all very important information. Illnesses can become chronic or recurring problems if they're not understanding or they can't translate what you're saying. All translates into higher healthcare costs. So it would certainly pay off to pay attention and identify and potentially head off some of these social issues, because it could affect our outcomes with our patients. And so the impact of addressing these social needs could be substantial to your bottom line. Next slide. Okay, so transportation is another one of our OASIS questions, and this one is it's very directly tied to some coding situations. We have lots of codes for transportation insecurity and transportation issues. So you certainly want to be asking about their transportation information, because if they're not getting to their medical appointments, like Sherri said earlier, if they're having to take two different buses to go across town to get to their doctor's appointments and things, and they wake up not feeling good, they're probably going to cancel that appointment and not even go. So that becomes a huge issue when you're talking about trying to get medication straightened out or looking at, signs and symptoms of chronic illnesses. So that can have a huge implication. So knowing that there's an issue with the transportation is pretty big when you're talking about your outcomes and your effects and how effective your plan of care is going to be with these patients. So getting this information is important. So asking the questions, did they need transportation for anything in the last 6 months? Have they gone anywhere? Do they have trouble with it? However you want to phrase that. Have they had trouble getting to their medical appointments? That's for item A. Item B is pretty much anything else that they have to go to. Any appointments maybe with the Social Security office, appointments with getting groceries, all those things that are non-healthcare related, that would be an item B. And then, of course, if they're unable to respond or if they decline to respond, we have the same rules as in the prior questions. If they decline to respond, then we have to choose only choice Y. But if they are unable, then we ask caregivers and dig through notes and wherever else we can possibly get the information. So this item, you could actually have multiple choices. You could choose A and B and X, and it all be correct information. So gathering this information is very, very important, and then it can lead to some transportation insecurity codes, which we have for you on the next slide. So the transportation insecurity codes, we have to follow OASIS rules for OASIS items, but then we have coding rules for coding items. So how do they kind of coordinate together? Well, like we said before, you can code transportation insecurity. This is a social determinant of health code, so we can code it based on provider documentation. So what I'm referring to here is if your patient declines to respond to the OASIS item about their transportation issues, then you have to mark your OASIS question as the patient declines to respond. But if you obtain information from an additional source, maybe a caregiver pulls you aside after your visit and says, hey, I want to talk to you, and they follow you out to the car and they give you information about transportation insecurity, you can't answer your OASIS item any differently, because if the patient is coherent and they chose not to respond, you can't code it in your OASIS, but you can assign a Z5982 transportation insecurity code to your plan of care based on the clinical information that you obtain and document in the medical record. So it's information, so you can code the information even if you can't answer the OASIS question because the patient refused to give you that information. Does that make sense? Hopefully that's clear as mud, right?
Yes.
Okay.
All right. Yeah, thank you. Social isolation, D0700. I think we all kind of realized the importance of this when we went through the pandemic. Again, when you have somebody that is suffering from social isolation, it can lead to a host of problems. And studies have indicated that belonging, whether it's to family, friends, social organizations, volunteer organizations, church, they are all related to living longer, better, healthy lives. Social isolation may be perceived and not actual. And I think that's important. I have an aunt, for example, she'll tell me all the time, the kids never come see her. You'll find out they've been delivering her meals and doing X, Y, and Z. She feels they should be there hours. So her perception is that they're not there. So we're going to go by that, patient's perception. So that means too, that the patient is the only source for this information. So they have to self-report. No other information is needed for this item or used. Ask the patient, how often do you feel lonely or isolated? And that's where you're going to get your answer. And next slide, please. Some of the coding around social isolation, Z60.4, social exclusion and rejection. Z60.9, problem related to social environment. Now we've got a couple here, and the trick is really in the index, right? They are a little vaguer, the codes. Z65.8, other specified problems related to psychosocial circumstances. If you were to look in the index at risk for feeling loneliness, this is the code that you are going to have for that. Now, if you look in your index at risk for social isolation, what you're going to come up with Z90 1.89. Now, we use this code for other things as well, other specified personal risk factors. So again, if we see this as significant for this patient, that is going to be how you're going to find it. So the key is in the index to get to these codes. Next slide, please. All right, and Kelly's in my usual fashion, we have crammed a lot in here. So next steps for you as an organization, MSW evals, there's a hierarchy that needs to be in the agent for those that need to be responded to immediately versus quick, and what the expected turnaround time will be for various conditions. Our MSWs are usually really thin in our organizations. They are covering a lot of patients. Agencies may want to look at per diem MSWs for more complex situations when something's taking a little bit more time. Maybe an event has happened and they need to pull on somebody else. That would be helpful. Having participating community organizations with commitment to respond quickly to outreach for help from the agency. So again, maybe it's your local food bank and they know, hey, if this healthcare organization is calling us, we need to respond. They've got a true, a true issue here. Resources and tools for nurses. Role play, as we mentioned earlier, in your monthly meetings on sensitive topics, right? We don't want to do what we've never done before. The unknown is scary. So let's just get it out there. Let's have those conversations with each other as practice. The other thing I think is having the resources in our hand. I know when I used to be a home care nurse, I did not want to ask questions because if I got the answers, I didn't know what to do if I got certain answers. So we want to have crosswalks or, pathways for our clinicians so that if the patient has an immediate food need, for example, I'm going to call the MSW while I'm in the home. I'm going to notify the physician, receive orders that are applicable. I'm going to refer to this organization, this organization, this organization. And within 24 hours, we need to have some kind of, food in the home, or we go to step 2. Health literacy friendly tools, again, things that aren't real wordy, more graphic oriented. Again, we want to have probably 5th grade reading level on those, but arming our clinicians with those stoplight tools are very, very good. They're color coded. It puts that management into that patient's hand, which is really important if we're going to have those better outcomes with those patients at risk for social determinant of health problems. So next slide, please. All right, Jan. Oh, no, Kelly. I think, Kelly, we're going to go over this. Sorry, Jan. Yeah. I almost put you on the spot there.
All right, so on the next slide here, this is going to be our scenario. It's kind of our segue into next month's talk. So this is our scenario for next time so that you can be thinking about this and tune in next month for the answer to this scenario. So we have an 81-year-old patient admitted to your home care agency for recurrent falls, 6 falls over the last 2 months due to his Parkinson's disease. But the family reports some confusion, especially in the evening, and lack of safety awareness when completing routine tasks and self-care, as well as patient often forgets to use his walker when walking around in the home. Patient has multiple throw rugs as well as several small dogs in the home and refuses to address these safety issues related to these. The patient lives alone, but the family members stop by morning and evening to help with meals, and patient also receives Meals on Wheels for lunch daily. The physical assessment shows the patient requires multiple attempts to get out of the chair, fails to use the walker when ambulating, and falls against the wall when ambulating due to a loss of balance. The PT eval on day 7 indicates the patient is able to walk 50 feet with a walker with only standby assistance. Comorbidities include vertigo, dementia, diabetic neuropathy, with documented loss of sensation to bilateral feet. So the following OASIS items are made available. So they're giving you the cognitive functioning is scored as a 3. When confused is scored as a 3. The cognitive, behavioral, and psychiatric symptoms, they scored 1 and 2, which is the memory loss and trouble making decisions. And then the BIM score of 8. And the CAM is answered as yes. So the question is asking, what is the best coding option for M1850 transferring? the GG170D, which is the sit to stand question, and the GG170E, which is the chair to bed to chair transfer question. So then you have your answer choices. So tune in next month to see the answer to this scenario.
Thanks, Kelly. And here's some resources from Kelly and Sherri's presentation. And thanks to both of you, Sherri and Kelly, for that, all that great information on the social determinants of health.
You're welcome.
I want to let folks know I had some issues with uploading the handouts for this call, for this live call. So I will be working on those, and they will be posted on the OC website. So you'll be able to refer to them there. I'm sure you're going to want to look at that scenario in a little more detail as you think about the right answer. So if you hop over to the OC website a little later today, I should have those posted. So thanks for your patience with that. And if you are an OC member, I just want to point out a resource that's a great help that is eligible for an OC member discount. And so that's what we're featuring in today's OC discount product spotlight. Decision Health's Coding Companion is the perfect educational resource to use in conjunction with your coding manual. It's your guide to accurate coding and compliance with expert guidance and comprehensive decision trees to help you navigate the ICD-10 code set. And OC members receive a 20% discount on this book. So you can find that on the Decision Health website, and it really is a helpful resource. And now it's time for What's New with OC, where we share updates from the Association of Home Care Coding and Compliance. And if you are an OC credential holder who's earned an HCS-C, HCS-D, HCS-H, or HCS-O credential, there's still time to take our annual survey to share your feedback about our credentials. As OC continues to grow, we want to know what we can do to help you in your career. How does your credential help you professionally? And how can OC support you? To help us gather your input, please take a few minutes to share your thoughts and tell us how we can support your professional survey by completing, or professional career by completing this survey. I'm going to put the link in the chat on this live call, and then it will be in the handouts for folks who are listening later and want to download those handouts from the OC website. Thanks so much. I really appreciate your sharing your input, and look forward to seeing what you have to say about what we can do to continue to serve you. And we hope you've enjoyed this episode of OC Talk. Thanks again, Sherri and Kelly, for all the great information, and thanks to all of you for tuning in. You can find OC Talk on your favorite podcast app if you'd like to re-listen to this episode on the go. We hope you'll join us again in April when we will be covering some coding updates, and you can always access the recordings on the OC website as well. If you have any suggestions for future guests, topics, or ideas about the format of the show, please send me an email at jan.milliman@decisionhealth.com. Thanks so much for listening. We'll see you again next month. Take care.